picture this. You're in a foreign country, right? And maybe you're there for work, or, maybe it's that dream vacation you've been saving up for like 3 years.
Oh, yeah, the stakes are high.
Exactly. But right now, you are definitely not dreaming, because your head is just pounding with the rhythm of a bass drum. You're shivering in this heavy sweater, and you finally manage to, drag yourself into a local clinic.
The worst feeling.
It really is. The fluorescent lights are buzzing, the smell of that clinical sanitizer is just overwhelming, and the staff behind the glass are speaking this rapid-fire English. They're looking right at you, waiting for an answer, and you feel like you might actually faint.
Right, because it is an incredibly high-pressure scenario. I mean, the cognitive load is just immense there.
So today's deep dive is designed to entirely dismantle that exact panic. We're looking at a really fascinating stack of sources today. We've got medical English as a second language curriculum notes, some linguistic research on how humans communicate physical pain, and even actual clinical triage protocols.
Yeah, and the mission here, our goal for you today, is to build a highly practical survival guide for the doctor's office. This isn't just a vocabulary lesson. It's about ensuring you know exactly how to advocate for yourself and get the right treatment, even when, your cognitive resources are running on absolutely empty.
I'm honestly so relieved we're tackling this, because navigating medical English causes just profound anxiety. There's this looming fear of saying the wrong thing, or, I don't know, getting the wrong medication, or simply freezing up completely.
Well, we are going to map out the entire physical journey of a clinic visit for you, starting right at those front doors. Because before you ever even see a doctor, you hit the first barrier, which is the reception desk.
Oh, the dreaded reception desk.
Right. You were immediately hit with administrative vocabulary, terms like insurance coverage, copay, and prescription.
Which honestly feels like a total bureaucratic maze when your brain is already foggy from a fever. But actually, let me push back on this process a little bit.
Sure, go.
If I am standing at that reception desk, right, and I'm sweating, I'm shaking, shouldn't it be enough to just sort of stagger up to the glass and say, I'm sick, please help me?
You would think so, but no. Clinics operate on a very strict system of triage. The person at the reception desk isn't just like taking your name down. They're running a rapid risk assessment.
Wait, really? Just the receptionist?
Oh, absolutely.
Yeah.
They need to categorize you immediately to determine if you're having, say, a minor allergic reaction that can safely wait 30 minutes, or if it's a life-threatening cardiac event that needs intervention right that second. So precision is your actual ticket through that door.
Okay, so they need data to sort you. That makes sense.
Exactly, which brings us to a critical linguistic distinction you have to make the moment you walk in. And that is the difference between symptoms and conditions.
Right. The sources spend a lot of time on this.
Yeah, because a symptom is what you feel. A condition is what you have. When you walk into the clinic, you almost never know the condition yet. I mean, diagnosing the condition is the doctor's job. Your job is to accurately report the symptoms.
And the source material highlights a couple of really fascinating linguistic patterns for reporting those symptoms. The first one is taking a body part and attaching the suffix ache to the end of it. So we say headache, stomachache, earache, toothache.
Right, the classics.
But as an English learner, you quickly realize you can't just slap ache onto literally anything. Like, we don't say eye ache or finger ache.
No, we definitely don't.
Yeah.
And the linguistic history behind that is genuinely fascinating. The body parts that take the ache suffix, so head, stomach, tooth, ear, back, those are all derived from ancient, core, Old English words.
Oh, wow.
Yeah, because they are the oldest words in the language for our anatomy, they sort of seamlessly combine with the Old English verb acan, which meant to suffer or throb.
Oh, that makes so much sense. So later medical terms, or more specific body parts that entered the language through, like Latin or French, they just didn't get that Old English treatment.
Exactly, they didn't. So for anything outside of those core Old English body parts, you have to shift to the second structural pattern, which is the phrase, I have a, followed by the specific noun.
Got it.
So you wouldn't say, I am fever, you say, I have a fever. Or, I have a sore throat, I have a rash, which means your skin is, red and inflamed.
You literally own the symptom, I have a cough.
It's fun on.
Okay, so let's say we've successfully communicated our basic symptoms at the reception desk. We get called back. We go sit on that really loud, crinkly paper on the exam table, and the doctor walks in. Now we have to upgrade from that basic identification to some nuanced description.
Because the doctor needs to know the exact texture of your discomfort.
Describing pain to a doctor always reminds me of describing a suspect to a police sketch artist.
Oh, that's a great way to think about it.
Right, because if you just run into a precinct and yell, "A guy robbed me, he was bad," the artist has absolutely nothing to draw. They need specifics like jawline, eye color, height. If you just sit on the exam table and say, "My stomach hurts," the doctor is basically flying blind.
They really are.
Yeah.
And medical English has highly specific terms for that sketch artist. Let's look at the four main descriptions of pain from the linguistic research. First up is sharp pain.
Okay.
This is sudden, it's intense, and it's highly localized. It feels like a needle or a knife.
So if I tell a doctor I have a sharp pain in my lower right abdomen, I'm drawing a very specific sketch for them.
You are immediately signaling a potential appendicitis or maybe a localized nerve issue. Now contrast that with dull pain. A dull pain is a constant low-level ache. It's diffuse.
Like it's spread out.
Yeah, exactly. It points the doctor away from acute nerve damage and points them toward deep tissue issues, muscular strain or, chronic inflammation.
Then we have throbbing pain, which is incredibly descriptive. It feels rhythmic. It feels exactly like a heartbeat, but isolated in a place where a heartbeat shouldn't be that noticeable, like, I don't know, inside your skull or in a swollen joint.
And throbbing is a literal diagnostic clue for a doctor. It signals vascular issues. The throbbing is quite literally your blood pulsing against inflamed blood vessels or tissues. It tells the doctor to look at vasodilation or blood pressure factors.
That is so interesting. Finally, we have pain that comes and goes, intermittent pain. It hits you, it vanishes completely, and then it returns.
Which often points to smooth muscle spasms, like what you might experience with kidney stones or severe indigestion. So combining the body part with the specific type of pain that does the vast majority of the doctor's diagnostic heavy lifting before they even examine you physically.
But, practicing these isolated terms is one thing. Retrieving them under pressure when your head is actually pounding is another thing entirely.
Oh, for sure.
We need to do a stress test. Let's play the symptom diagnosis game right now to build some muscle memory.
Yes, I love this. A simulated low-stakes environment is the absolute best way to prepare for the high-stakes reality of a clinic.
Okay, so for you, listening right now, here are the rules. I am going to act as a patient presenting a specific scenario. Your job is to act as the doctor and diagnose me out loud using the correct English phrase. I'm going to give you a clear 5-second countdown to shout your answer before the expert reveals the diagnosis.
Sounds good. I'm ready.
All right, scenario 1. Doctor, I feel terrible. I ate some really questionable sushi from a gas station last night. Now my stomach is making loud noises, I have a sharp pain, and I need to run to the bathroom every 10 minutes. What do I have? Shout it out. I'll give you 5 seconds. 1, 2, 3, 4, 5.
Okay, the target answer here is food poisoning.
Food poisoning. It sounds intense, but it is the standard phrase for foodborne illness. Okay, scenario 2. Listen closely. Doctor, it's springtime. Every time I go outside, I start sneezing uncontrollably. My eyes are constantly watering and I have a dull headache. What's wrong with me? Shout it out. 1, 2, 3, 4, 5.
You are suffering from seasonal allergies.
Seasonal allergies. The pollen is triggering that whole histamine reaction. All right, scenario 3. This one's physical. Doctor, I was in the kitchen shopping vegetables and my knife slipped. I'm bleeding, but it's not deep enough to require stitches. I just need a bandage. What is this called? You have 5 seconds. 1, 2, 3, 4, 5.
That'll be a minor cut.
A minor cut. And that distinguishes it from a severe laceration, which you'd need the ER for. Okay, last one, scenario 4. Doctor, my vision is getting blurry. The left side of my head has an intense throbbing pain. It feels like a heartbeat in my skull, and I just need to lie down in a completely dark, silent room. What do I have? Shout it out. 1, 2, 3, 4, 5.
You are experiencing a migraine.
A migraine. The throbbing detail and the light sensitivity are the absolute dead giveaways there.
And running through these scenarios, it builds a cognitive bridge. You aren't just memorizing vocabulary from a list, you're attaching it to a narrative, which makes it so much easier to recall when you're actually in pain.
Exactly. So now that we have the individual symptoms and the pain descriptors down, we need to string them together in a real-time conversation. Let's simulate the actual consultation room.
Okay, let's do it.
You play the doctor, I'll play the patient, and we'll just do a continuous run-through.
Hello. What brings you in today?
Honestly, doctor, I've been feeling really off lately.
I see. And how long has this been going on?
Well, it started about 3 days ago with a dull headache, and now I have a pretty bad sore throat.
Okay. And what have you taken for it so far?
Just some over-the-counter pain medicine, but the relief comes and goes.
Based on your symptoms, I'm going to prescribe some antibiotics. I want you to take these twice a day.
Okay, I'm going to pause the role play right here for a second because as a patient, The doctor just gave me instructions, and maybe I didn't fully catch the nuance of the dosage. So I'm going to deploy what the source material calls a fluency saver. Okay. Unpausing the roleplay, doctor, just to be clear. Should I take these on an empty stomach or with a meal?
You should take them with a meal to avoid an upset stomach.
And scene. Okay, let me be completely vulnerable for a second about that fluency saver phrase, the just to be clear part.
Please do.
As someone who has spent years trying to navigate second languages abroad, stopping a medical professional in their tracks to ask them to repeat or clarify themselves, it feels completely humiliating.
Well, I totally get that.
It feels like a massive failure, you know? You want to project that you understand, that you're fluent. Asking a busy doctor to slow down feels like confessing your language skills just aren't good enough.
Right, but we need to completely dismantle that perception today. The clinical protocols we're looking at in the sources stress this constantly. Native English speakers ask these exact clarifying questions on a daily basis.
Wait, really? Native speakers?
Yes, because the instructions are inherently complicated. Medical terminology and dosage schedules are complex for everyone, regardless of their native tongue.
Okay, that makes me feel a lot better.
It should. Asking, just to be clear, should I take this with a meal, is not a signal of poor English. It is a signal of high-level self-advocacy. You are prioritizing your medical safety over your linguistic ego.
Wow. That reframing changes everything, honestly. So navigating the clinic is the high-stress part, but how do we talk about our health in everyday life? Like, if a colleague asks how I'm doing, I don't want to just say, I am sick. I want to use some of those conversational fluency power-ups.
It's a fantastic, very natural idiom for that pre-illness fatigue is saying, I'm feeling a bit run down.
I love that one. I always picture an old smartphone battery that's stuck at like 5%.
Yes, exactly.
You use it when you aren't completely bedridden yet, but your energy is entirely depleted, and you just know you're catching a cold.
Right. Another powerful conversational tool is the phrase, it's acting up.
Oh, I hear that one all the time.
Yeah, and it basically personifies the illness or the injury, treating it almost like a misbehaving child. You use it for chronic issues. So if you have an old knee injury from playing tennis, you wouldn't say, my knee is acting up the very first time you heard it.
Right.
But years later, when it rains and it aches, you say, my bad knee is acting up again.
Okay, what about the other side of the curve, when the illness is finally fading?
The really natural native phrasing there is, I am on the mend. And the etymology here is wonderful. Mending is a traditional word for repairing a physical tear in fabric, like sewing it back together.
Oh, like mending a sock.
Exactly. So when applied to human biology, if you are on the mend, your tissue is literally repairing itself. You aren't operating at 100% yet, but the repair process is underway.
Okay, before we move on to the most common traps, we should briefly touch on the dosage vocabulary you mentioned during the role play. The doctor writes the prescription, and we have to understand the frequency.
Yeah, and the phrasing there is usually very strict. It's once a day or twice daily. And then you have the environmental conditions of the medicine, things like with food, on an empty stomach, or before bedtime.
And misunderstanding these isn't just a minor grammatical error, right? It physically alters the absorption rate of the chemical in your body.
It absolutely does. It can make the medicine useless or even harmful.
Which transitions us perfectly into the traps. The source material outlines 3 major mistakes language learners make at the doctor's office, and some of them are genuinely dangerous. Mistake number 1 is using pain as a verb.
This is so common because many languages across the globe treat the concept of pain as an active verb, an action that a body part is performing. So a direct translation leads learners to say things like, my head is paining.
And to a native ear, that syntax just completely stalls the conversation.
Right, because English treats pain conceptually as an object that you possess, like a noun. That is why the structural fix is to say, I have a headache, taking ownership of the object. Alternatively, you can use the verb hurt to describe the state, saying, my head hurts.
Okay, mistake number 2 is oversharing. Giving the doctor way too much narrative context. Actually, let me try to roleplay this trap. You be the doctor, ask me what's wrong.
All right. What seemed to be the problem today?
Well, doctor, I've had this stomach issue, and it really reminds me of back in 2018 when I went on a trip to the mountains with my brother, the one who lives in Chicago, and we ate this weird cheese, which my mother always warned me about because dairy is tricky for our family, and ever since yesterday, I just feel like...
Okay, let's pause right there.
I couldn't even finish.
As humorous as that sounds, it's actually a very common defense mechanism.
Right.
When we are nervous in a second language, we tend to overcompensate by over-explaining. We want the doctor to have the entire historical context so they don't misdiagnose us.
But doctors operate on, like, algorithmic pattern recognition, don't they?
They do. They have a really tight schedule and a very specific diagnostic filter they are trying to run your words through. When you give them a sprawling narrative about your brother in Chicago, you are just introducing noise into their algorithm.
So you're accidentally hiding the real problem.
Exactly. You actually bury the vital symptoms. So keep it incredibly brief. Stick to the body part, the type of pain, and the duration.
Keep the data clean. I like that.
Yeah.
Okay, the third and final trap is tense confusion, and this one has terrifying real-world
This
consequences.
is serious. It's using the future tense when you mean the past tense, saying, I will take the medicine when you actually mean you already took it.
Oh, wow. So if the doctor asks what you've done for the sharp pain, and you say, I will take 2 strong pain pills, the doctor registers that your system is completely clean.
Right.
And they might immediately administer a shot of heavy medication right there in the consultation room. But if you actually meant, I already took 2 pills an hour ago, you are suddenly facing a potential overdose.
Exactly. Verb tenses in a medical setting are not just grammar exercises. They are matters of physiological safety. You must clearly establish the past tense. I already took the first dose.
Oh, what we have covered a massive amount of ground today, completely unpacking the linguistic journey of a clinic visit.
We really have. And the survival guide basically boils down to a 3-step system. Step 1, explain the body part and the symptom clearly. I have a stomach ache.
Right.
Step 2, describe the specific texture of the pain. It is a sharp pain that comes and goes. And step 3, always use a fluency saver for the treatment plan. Just to be clear, do I take this on an empty stomach?
That is so practical. I actually want to issue a challenge to you based on that system. Your homework for this deep dive is to stand in front of your bathroom mirror and practice this exact sequence.
Oh, I love mirror practice.
It works. Pretend you have a throbbing earache and explain it to your reflection as if your reflection were the doctor. Run through the power-ups too. Tell the mirror you are feeling run down. Building that verbal muscle memory in a safe space removes the panic when you're actually in the waiting room.
That's excellent advice. And to pull all of this together, I want to leave you with something to consider about the future of how we handle these situations.
Oh, okay. Let's hear it.
We hear constant buzz about AI translation tools, right? It is very easy to think, well, if I get sick in a foreign country, I'll just speak into my phone and let the app talk to the doctor.
Which sounds super convenient, honestly.
It does. But physical pain is a deeply subjective, incredibly isolating experience. A machine can translate the literal words, sure, but a doctor relies on your hesitation, your tone, the actual wince on your face when you finally find the word for throbbing.
Oh, I see. The machine kind of strips away the humanity of the interaction.
Exactly. True medical self-advocacy requires a human-to-human linguistic connection. Empathy and diagnostic intuition just cannot be entirely outsourced to an algorithm. Mastering these phrases ensures that when you are at your most physically vulnerable, your voice and your agency remain entirely your own.
Reclaiming your voice when you need it most, that is really powerful. So the next time you find yourself shivering in a foreign waiting room, remember this. You have the precise vocabulary, you understand how to describe the nuance of the pain, and you have every right to look the doctor in the eye and say, just to be clear, good health to you all, and we'll see you on the next deep dive.